Ladies and gentlemen, it's time now to start the second half of the day, the second session, which will be kicked off by Robin van Kessel. I see him already here. So please come here and
I should have worn a different scarf.
the floor is yours.
Where's the clicker?
Clicker, yeah, that should be this one.
Thank you. Lovely. All right. Lovely. Well, I hope everyone enjoyed their lunch. And I promise I'll account for an after-lunch dip during the coming hour and a half. Welcome. My name is Robin. I am here from the slightly less sunny London. And I'm here to talk about the financing and reimbursement of digital health technologies within health systems at a very high level over the coming 10 minutes. So in determining how digital health technologies are financed or reimbursed or in any way, shape, or form paid for, currently we are trying to fit them into the existing models. And the ones that are predominantly used, I've listed on screen just as a refresher for those who may not work in this every day. The fee-for-service system that basically says if I use a digital health for one use cycle, 30 days, if that therapy takes 30 days, then you're going to get a set amount of money for that. Capitation is a sort of budget that is based on the number of people covered within a certain region, could be geographic, could be otherwise. Diagnosis-related groups, basically you get paid by a combination of factors that reflect the expected resource utilization based on a patient's diagnostic and risk factors. And finally, the pay-for-performance scheme that indicates basically if we reach a certain threshold for a certain indicator, that's where you get a reward for that, a monetary reward. Now, what's interesting to note is that none of these fit digital health perfectly. All of these have their risks and benefits associated with them. For instance, fee-for-service, very easy to implement, very easy to track how many times a digital therapeutic is prescribed. You pay on the basis of that. Capitation, slightly more complex, but still doable. DRG is also slightly more complex, but still doable. Pay-for-performance, possibly the one for digital health technologies that holds the most potential, yet the least used. I'll try to go into why later on in the panel discussion. So, in practice, how are digital health technologies actually reimbursed? Well, most of them are part of insurance schemes. And I can say this based on an analysis of about 10 countries, well, 8 countries. In the European region. And where they're part of insurance schemes, they are in reality part of some capitation, DRG, global budgets, or the fee-for-service approach. There are also certain countries that offer reimbursement through innovation schemes. So basically, a government agency, an NGO, will offer a lump sum of money for the implementation of a digital health technology. And the winner of that grant, of that budget, will be able to finance the costs of deployment through that, thereby not directly burdening the health system with the costs. There's a distinct example that I'll go into in a couple slides of an NGO basically saying we recognize the value of this digital technology for our patient group. Therefore, we will purchase it and distribute it for free amongst all our members. And finally, we can't ignore the possibility of the commercialization of digital health technologies. Direct distribution from the provider to the patient, where health professionals may not play as active as a role as they maybe should. As I said, the current practices really rely heavily on fee-for-service because they are easy to implement. We don't really know all that much yet about digital health technologies in the sense of what are the exact benefits that they can produce, and even taken broader, what is their general utility? Why do you use a digital health technology over another type of technology? Is it purely clinical? Does it extend beyond the clinical realm of outcomes? So long as we don't understand enough about these questions, we will probably see fee-for-service processes continue on, because capitation, DRGs, pay-for-performance schemes all require us to have a certain level of understanding of these outcome measures and how we value those outcome measures. Here is also where I will point out the example of Alzheimer Netherlands, which basically saw the benefit of an Alzheimer-specific digital health technology, purchased the license for all of the members of Alzheimer Netherlands, and now distributes it freely amongst their members, which is really, really clever when you think about it, because one of the key bottlenecks, aside from reimbursement for the uptake of digital health technologies, is the fact that people only understand the value of digital technologies after having experience with them. So let's remove that barrier. The NGO takes care of that in this case, and is something that when we're looking to implement digital technologies in health systems, maybe we should do more. But again, we need to be able to understand the value of digital health technologies for that. There's the aforementioned innovation funding, which is rather prevalent in the UK, the Netherlands. I think Germany does some of it as well. And I want to say France has a number of rather large-scale grants for this. In any case, as I kept alluding to, it's not about the financing mechanisms. The uptake of digital health technologies is actually not bottlenecked by financing mechanisms. Yes, they're not great, but they're also not bad. Like, they'll do the trick for now, until we figure out exactly what the place is of these digital health technologies in our health system. We can rely on the tried and true financing mechanisms that we have modeled our health system around so far. And really, the big question is, I suppose the big question is, does the thing have a pointer?
Yes, the green one.
The green one, lovely. The big question is do we only have to look at clinical value? I mean, we are working in healthcare, but we speak of health systems, not healthcare systems. That goes beyond healthcare. So do we only then, for the implementation of these technologies, look at clinical value, time in hospital, readmission rates, burden of disease, comorbidities? Or do we also look at do we need to start looking at certain forms of social value? How long does it take for a patient to return back to employment, to return to their education? How much does that gain us in the long term? What are the benefits of treatment or recovery in familiar social settings? Recovery at home. Does that have certain social value with it that you don't get in a hospital? I mean, one of the examples that comes to mind is the reduced risk of AMR infections with antimicrobial resistant bacteria. That risk increases the longer you remain in hospitals. Finally, in terms of financing itself, we might be looking towards a system of more outcome-based financing over the next few years as we gain more clarity about the value that digital health technologies can offer. And it's important to note that it's not about choosing either activity-based financing or outcome-based financing. These two can coexist. The OECD provided this wonderful schematic about how that might look like, although the lines are slightly blurred on the screen, I see. I hope that the slides are going to be distributed afterwards where the total picture is better visible. In any case, these managed entry agreements or outcome-based financing agreements have a financial and a performance-based component where, again, we still have our expenditure cap. We don't want to spend more than X on a particular digital health technology at a patient level, but also at a population level. I didn't realize that was that funny. There's an element of price volume agreements as well that can be decided beforehand. But then, once we have this financial aspect all figured out, or even somewhat figured out, we can look at the performance aspect. So what results are actually realized when this treatment is being deployed amongst our patients? And by extension, do we actually pay for the full range of benefits that we were promised? If that is not the case, a more outcome-based approach might be something that we are going to have to look into, and especially with digital technologies, digital therapeutics. One of the core components of digital therapeutics, you have to use it in order to gain the benefits from it. If you stop halfway, why do we expect the health system to still pay for the full extent of it? That might not make sense in certain contexts. It's a tightrope to walk, though, and it's basically ask ourselves how much risk is a health system expected to take for the treatment adherence of the individual patient. I don't have the answer for you on that, but it is a question that I hope in the coming years we'll get more clarity of as this financing mechanism or these types of financing mechanisms are explored further. As I said, those types of outcome-based financing mechanisms need to be paired with value frameworks, or not even value frameworks initially, but utility frameworks. We need to know what on earth these digital technologies are actually doing. And we need to know that from robust evidence and not hearsay. We need to know about the characteristics, their intended use, performance, safety, effectiveness, comprehensive, that lead to a comprehensive value assessment in the end. And I'm not really sure fair enough. The way we get to that value assessment is both by clinical trials, both by randomized control trials, observational studies, etc. But also, we shouldn't discount the fact that these technologies are generating the evidence for us. We need to be able to leverage that, and luckily, the EU has made that considerably easier recently with the Data Governance Act and the EHDS that allow access to a good number of health data embedded in these digital technologies for further analysis. Though that does mean that the interoperability between all these apps needs to be taken into account, which opens up a whole other can of worms that I'm not going to bore you with today. Finally, let's talk a bit more about the valuation of digital health. Well, certain value frameworks are emerging, but they are fairly clinical. They're not necessarily catered towards the social value, towards the, maybe not even social, but the non-clinical value that digital health technologies can offer. That doesn't make them less important, but only incomplete. And they will work as a temporary framework until a more elaborate one has been developed. But in order to get these value frameworks, especially newer ones that do incorporate social value, implemented, we will face tremendous challenges because I'm pretty sure everyone here is aware of it, but health is a notoriously change-resistant field. And for that, we will need to have buy-ins from early champions that really are able to communicate why these value frameworks are needed, why these expanded value frameworks are needed. And in order to achieve that, we need to make sure that all the stakeholders that we have in the health sector are heard. We need to make sure that our patients are heard. I heard that we have a colleague from the European Patient Forum here today. We need to make sure that the health professionals are heard. We need to make sure that the citizens are heard, or as I believe Monza called it, the patient of tomorrow. We need to make sure also that the developers are heard. It's not only about the healthcare delivery section, it's also about the health innovation part of our health system. All of these need to be involved in creating these value frameworks because all of these have a stake in this process. I covered this at length at the moment. I'm not going to go over this again and again and again. Except to say that if we don't consider the social benefits and values, it may result in the undervaluation or misidentified risk profiles of products. We might think they don't offer as much as they maybe do, or we think that they might be riskier than they actually are. So, some parting thoughts. We can create a number of short-term wins at the financing level by ensuring that financing and reimbursement rates are competitive with traditional care. If you have an online consultation or an in-person consultation, make sure that they are financed in similar ways at a similar level so that systems that still rely on volume-based volume-based financing, which are pretty much all of the systems in the world right now, they don't punish professionals for trying to innovate. Italy is a very good example of this, having introduced a payment parity system during COVID. We need to make sure that at a regulatory level, we distinguish digital therapeutics from other digital innovations in health, for instance, well-being apps. These are actual medical devices. I'm preaching to the choir here, but this is not as evident in policy across the board. Germany, France are two countries leading, Finland as well, leading the charge here by really saying this is a class of digital technologies that is fit for use in the healthcare sector. And by creating these short-term wins, we can open ourselves up to more long-term gains, understanding the value of digital healthcare beyond the clinical realm, revising health technology assessments to incorporate this new dimension of value, ensuring that we are paying not only for the best clinical outcomes, but for the best well-being outcomes for our patients. And finally, we need to make sure and to keep testing our regulatory framework to make sure that it continues to protect our citizens and to serve the interests of society at large. If you're interested to read more, this is a handful of the work that we've produced at the LSE about this topic. And thank you very much for your time.
Thank you, Robin, for a very insightful setting the scene. We have some time for questions now, so I see one hand there and one here. No, it works. It should work now.
Okay, thank you. Yeah, thank you for a very interesting talk. I was just wondering, could you comment on how do we get paid for something that doesn't happen? If we want to use, have tools that enable us to do prevention, for example.
Mm-hmm. Right. That's a really good question. And this is where, I think over lunch I was discussing this with one or two people. This is where the concept of a counterfactual comes in. So when developing our risk profiles, the risk profile of a digital technology, it's important to understand what benefits it gives and during the development and the deployment, we get a certain level of benefits, we have a certain amount of risks. But equally, if we don't develop and we don't use the tool, what is the state of play then? And what are the risks associated with not deploying that? In preventative care, we're not going to be able to measure a lot of the clinical or maybe even the social elements. But we might be able to say, well, if we don't do it, then this is what happens, and this is the costs associated with them. So in a sort of inverted way, you can say, well, these are the savings, both health savings and financial savings that we're able to realize if we invest in this tool now.
Thank you. Vincent, please. Maybe, yeah, I don't know if they can just turn your mic on. Or
Not yet for that mic.
Beyond the social value, how can we take into account the, let's say, the societal value, the value for the, let's say, digital health technology or digital therapeutics can brings for from for example, for epidemiology perspective, like if you are able to collect and process in real time all ECGs from the population, then you're able to have new information from, let's say, health organization perspective that gives you also a value from these technologies compared to like non-connected ECG or non-intelligent ECGs and so on. That is useful. No, that could be useful.
Yeah.
Like. But how do we measure them, or how do we take into account in some frameworks?
I suppose here's where I'm going to contradict myself slightly, because then the question becomes how much of the utility of the data use should the collector be rewarded? What I mean by that is if we look at primary health data that is health data that is used for primary healthcare, for even secondary healthcare, but data that is currently used in a healthcare setting is often leveraged for these epidemiological purposes. These are not necessarily the patient or the citizen is not directly rewarded monetarily, but they are rewarded by an optimized health system. So we're going to have a discussion kind of with all of the stakeholders at hand about what part of our kind of data landscape, what part of our data pool directly contributes to improved services, directly contributes to an improvement in health systems. How much of that is the reward in and of itself, and how much further compensation is actually necessary? Because when you talk about the utility of data and the way that it feeds a health system is nothing more, well, it is a lot more, but at a foundational level, it uses data for each and every part of its functioning, and in doing so, it is able to cater to the needs, theoretically, of all of the citizens that fall within that health service or health system.
Thank you, Robin. I think we can move on to the panel now. Thank you for the insightful keynote. I would invite you to step on the stage and pick a seat, as you're the first one. A second one, I would invite on stage Jaanus Pikani, the moderator of the event. And then also the panelists, Jarika, please, Vincent, and Thomas. And the clicker is here.
Thank you very much. How it works. Okay, so it's my pleasure to actually be here moderating this session. The topic of financing of the digital software as a medical device, or DTX, has been up for some years already. And usually we hear it from either from the perspective of the startups or developers that the possibility to actually get access to the public funding is limited, because there is not the special sort of arrangements how to get financing. And as we know, there's always shortage of money if you are developing a new digital tool, and you have either to actually raise money for a long period, because there's also hurdles like medical device regulations, regulatory problems connected to this, and to actually get to the implementation, because the uptake of the tool might be not actually well demonstrated, the value is not well demonstrated, and the marketing, we know, is a very, very expensive part of the product development and implementation to the market. So that's why these topics are important. But from other hand, we might also ask, what is different from having digital tools to the current practice of medicine? Do we have different questions? If we have as a general problem, as we know and we see here, is a integration of different parts of services. Primary healthcare, secondary healthcare, social care, and also the part of the vocational care. So what is different on these tools? And that's why I think today we could actually see, is there any difference? I want to try to discuss this. And thanks to Robin, the insight was actually, I think, very good platform to start with. And we have been planning to give a round of tables. Robin has given the general overview, but we have now Jarika here, representing Estonian Health Insurance Fund, and Sand, who is actually representing the French Ministry of Health, the delegation of digital health, which is actually set up specifically to introduce the new tools, and was in January when we visited with a delegation with Minister Paris. Then also we heard that France tries to catch up with Estonian and be able to 2026 be able to actually reach to the exchange of prescriptions like we do with Finland. It was actually one of the theme what was presented by the representatives when we had a meetings there. And Thomas, which actually can give us insight maybe from first hand what is happening in Germany, although Robin has already indicated some features. So I would like to give the floor to Jarika at the first place to give some overview what is going on in Estonia.
Thank you, Jaanus. So I'm head of development of Estonian Health Insurance Fund, and I'll show you or share with you some of the experiences that we've got in the past 5 years, basically when we've had this subject under more in focus. So I created a small roadmap. On the upper level, there are different reimbursement decisions regarding digital health. And on the lower level, there are different pilot projects that have given us new knowledge about how to reimburse different digital health solutions. Well, 2020, everyone remembers that we had COVID. It made it very easy for us to bring teleconsultations into reimbursement. So basically what we did there was just pay the same for remote consultations as we did with physical ones. So that was the first reimbursement decision. It was quite easy. It was fee-for-service based, basically the same service, just using the different channel. Then from there on, we wanted to go on to remote monitoring services. That wasn't that easy, just to take another service and make it through another channel. So we did pilot projects. We had 4 different projects going through different levels of healthcare. We had 2 primary care projects that enabled easier communication with primary care specialists. And then 2 remote monitoring projects, one on remote monitoring of psoriasis and the other one on cancer patients. And through these projects, we got a lot of information about what are the options, how to reimburse, what are the goals of these different tools, because all of these tools had different, on some level, different goals. And why I'm talking about the goals, it takes us to why we need to different digital health solutions. Some of these are just another channel how to communicate. Some are actually, like DTX's definition, basically like medicines or an intervention that you do for improving the treatment outcomes. So we got a lot of information from there. During those pilot projects, we launched an innovation grant for different solutions to gather evidence that we need for making reimbursement decisions. What we realized that there are very many steps before that last evidence gathering study to get all the solutions to where they can start looking at the evidence. So the innovation process is a lot longer for different technology companies to get there, or the products to get there. And then in 2024, inspired by the results that the pilot projects on remote monitoring showed, we started probably from the different financing mechanisms, then I would say like global budgeting for primary care communication platforms. So we actually do pay for a different primary care providers for choosing a platform that would serve them best. First, we just make sure that it's safe and it has functionalities that we need. But we do, yes, support primary care like pre-visit platforms, which have been taken into use quite actively. So with the last year, we've come to from 30% of usage to 60%. So basically 60% of Estonian population now can access their primary care team via digital health platform. And now, basically this week, our care pathway pilots are starting. Also 6 different care pathway pilots from, they start here in Tartu as well, and these will be with the goal, or we're aiming at getting better, at getting the value, as Robin just said, like how to get the value measures so we could pay for the care pathway in the end, and that would leave much more doors open for remote monitoring or digital health platforms to be integrated into the care pathways if we'd pay for the care pathway. And these pilots actually will be working on the care pathway pilots also earlier on stroke and endoprothesis, yes, pathways. And probably the first reimbursement model will be in action in the second half of next year. So where we actually pay for the whole pathway. But the work that goes into creating those standards and those quality indicators is a lot more than I think most of us realize. And then we also have some of the remote monitoring platform studies going on right now, which would then give us knowledge either about the care pathway that we could reimburse or through the fee-for-service list that would give us the evidence that we need. So this far, we've been trying out different options. Our doors have been open for product owners. We are open to try out different things. We do have them going on, but what we haven't done, and actually we haven't set out a goal to do right now, is to set out a payment system and fix it. Because we just, for example, like what Germany and France have done, we just don't have enough resources to test the way that we can give money until we get the evidence. So what we've done is go like one example to the other. And right now, basically, both of the options that are here on that slide on the left side are open, but they're And I think the future looks the same way as Robin said, that different ways can coexist and will probably coexist. I think that for software for treating, managing, or preventing diseases, especially the ones that can be handled by the patient themselves, will probably stay in the medical services list or medical devices list. The problem here is that it requires enough evidence for the insurer to buy for the whole country, Estonian-wise, since we have only one insurer. And the evidence level is a lot higher. It's just not any buyer, but the evidence that you need to gather is basically comparable to medicines. So the randomized controlled trials that are usually a headache for all the quickly developing tools, etc. And the other option, and the one that we're tilting towards, is software for improving user experience or clinical processes, all the remote monitoring services that make it easier for the patient to be in charge, for the clinical process to be more optimized. Here, I really think that bundled payments or pathway-based payments are the way to go, because it brings the buying decision-making to a lower level. It doesn't have to be the insurer. The insurer can have their... time is up. Okay. The insurer can have their certainty of the efficiency by paying for value, and then the healthcare providers will have the chance to make the decisions on their own. Like, what do they use for creating the health outcomes? So that's what I think the future looks like, and both ways are right now under investigation. If we have companies that want to go further, we can discuss these, or how to give more evidence for choosing one or the other way. Our doors are open. Thanks. Oh, here's a lot of information from our website, if anyone wants to read more about the things that I talked about on the first slide.
Thank you very much. Before we just go on with intent, I have one question. This is, you mentioned these care pathways projects, and have you any thinking already been done if there will be multiple stakeholders involved in the care pathway? Do you have any model how to share the actually fee between them, or it's just to be worked out? Or
you mean who's the receiver of the the money or the reimbursement?
Yeah. If let's take hip replacement, the care and aftercare and rehabilitation, there is, if not tens, but at least 2-3 different service providers involved, and each sort of stage will end up with some kind of outcome. Sometimes the person has to go back. I understand that from the point of view of the financing body, it will be easier and maybe more productive to have this bundle payment based on some kind of final outcome. But the question is always how to determine how these group will share this revenue between themselves and how we'll measure it. And do you think that there can be also a problem that this will be so complicated that this won't work between them?
It can definitely be complicated, and I think it's a very good issue that you pressed on. And that's probably the cause why, for us, it's taken a lot longer than we expected at first to reach the first care pathway payment models. But I feel that probably it's going to be, from our side, one payment, and then the question is how to, for the outcome, and the question is how to share that, because the whole goal of the pathways is to make the hospital think about how the next steps are going to be. So probably there is complications, or it will be complex system of how to pay for the next steps, but that would help, like for example, the hospital after the surgery to get the patient to the next institution, not just out of the hospital door.
So to make it more simple, that you have one sort of contractor, like hospital, and hospital then subcontracts all other
Probably,
partners.
but I say that all the options there are open. It just needs to go in place, and probably for each pathway there might be slight changes.
Thank you. Yes, please.
Just to add on to that, we don't have to reinvent the wheel here, because there's two countries that at least I'm aware of that are already experimenting with this, with digital technologies, and that are Belgium and Israel.
Okay.
So if you want to know how, I think Belgium trialed this. I think officially the mHealth pyramid has been discontinued, but the evidence is still out there. You can see that they basically required each step in the care pathway to be monetized in some way, shape, or form. And on the basis of that, they made their lump payment, ensuring that there was a certain level of accountability. These are the costs incurred, so that's the one, or those are the ones that are being reimbursed. And if the allocation internally within the hospital or whomever was not done properly, well, that's for the provider in the hospital to then fight out. But at least there is a very transparent way of getting to these reimbursement levels that are of interest for the insurance.
So, Vincent, do you want to add here something on this question about the care pathway financing?
Yeah, but does it work? Oh, yes. Okay, thanks. Yeah, but not sure. Probably later in discussion, but
Okay, good.
just not.
But then, floor is yours.
Okay. So thank you very much, and really glad to be here. And it's nice to speak with such a number of people. I just want to ask the public before starting, like, who can raise their hand if they are, let's say, working for a medical device manufacturer. So, some of you, and who from that part are working for a digital medical device manufacturer and let's say digital therapeutics manufacturer. Okay. So, I'm Vincent Vercamer. I'm working at the French Ministry of Health, and especially my, let's say, my topics is the market access of the digital health innovation. And I'm not the one that is deciding what are we reimbursing or not in France, but I'm trying to define and work with my colleagues to define new frameworks and also to implement these frameworks for the manufacturers that apply and claim a reimbursement. The idea is that our focus is today is on the digital medical devices. Well, it's, let's say, in these DMDs, you have the software as the medical device. You also have the, let's say, software in a medical device. So because we have also devices that are hybrid devices with hardware and software, but whatever, the idea is that the main function, or there is a strong function that is taken and done by the software part. And the definition that I have for the DTX is that maybe a bit more restrictive than the one we are using, but the one I'm trying to use is the one published by the Digital Therapeutics Alliance with the international ISO standard. They published it last year, 2023. They say DTX is a health software, well, so far so good, intended to treat or alleviate, but they excluded the diagnostic and then other purposes. So they just say treat or alleviate a disease, a disorder, a condition, for example, a pregnancy or an injury, by generating and delivering a medical intervention that has demonstrates, that's the important part, a positive therapeutic impact on the patient's health. And that said, for example, for France, and I totally agree with what Robin said, is that we already have all the tools to reimburse digital medical devices. We created the PECAN, which is on the middle of the slide, to have a fast track for innovative digital medical devices that didn't yet finish the data collection to prove that they are useful, to demonstrate the benefits. What we call the common law, the standard framework, are already existing for a long year now. We have a new one, which is the list of the telemonitoring activity, which is a really recent one. That is bundle payment for healthcare professional and bundle payment for the manufacturer. And so that is, let's say, for the devices that can demonstrate that they are useful and they have a positive healthcare effect, like German like to say. And we also have this innovation funding. When you didn't have or you don't have yet your CE marking, you can apply, and you are in the middle of the, let's say, the clinical study, and this is a possibility also to get money from the French government. And the PECAN, it's a really new framework, and I would like just to talk about the idea is that we have this 1 year transitional and temporary reimbursement. So we do not create a new list of devices like the DIGA list. We just create a framework to reimburse specifically digital medical devices, so DTX or telemonitoring activity during 1 year, while the manufacturer is finishing, let's say, the demonstration and present the demonstration. So we say we share the risk. We are, let's say, we pay for a potential benefits. So we share we say, okay, we want to have a good balance between innovation and access to the patient to these innovations, and also, on the other hand, have a, let's say, finance and reimburse devices that have the potential to be useful. They don't have the demonstration yet, and we give them the money, but it's the how can I say? It's the fixed amount of money. So it's one size fits all price, and the idea is that we give an rapid access to the patient for this innovation. So the manufacturer already know what is the compensation, which is not a reimbursement. It's just a compensation for the 1 year, and then at the end of the year there is the price negotiation with the algorithm of the Ministry of Health that is discuss and say what is the fair price for this digital therapeutics. But that's, let's say, part of the standard of way of reimbursing medical devices in France. And the idea here was like for innovative devices such as the digital therapeutics for individual use and the digital medical devices that are used for telemonitoring activity, for remote patient monitoring, they can apply, they can get these amounts of money that are on the left. You have a maximum of 780 euros per year, and on the right, for the telemonitoring activity. And what I can invite you to do is to go to this website, Genius, that we have to make life easier for the innovators, and on it's all the frameworks are detailed and it's in English. So it's something we are doing with all the different governmental bodies. Thank you very much, and sorry for being a bit late on the schedule.
No problem. So, just maybe I will just ask one question here to be sure and understand that this seems to be the PECAN is to be so somehow to support clinical trials or the trials period that it's because if you take the MDR and these are medical devices, then you cannot actually release them to the market without having CE mark.
Yeah.
And then you have still in a process to actually prove that this is actually an efficacy and the security. So how do you feel how it actually reconciles with the MDR requirements?
So PECAN the purpose of PECAN is to give rapid access to the patients and to have a fast-track evaluation. Of course, there are things that we do not negotiate. There are prerequisites, such as the valid CE marking, whatever, if it's an MDR or an MDD, while it's valid, let's say. But it's a prerequisite. Like, we don't take applications from manufacturers that don't have the CE marking before applying. Then we evaluate that, but the 1 year is really short. So the studies, the data that could be not necessarily clinical investigations, could be also data collection studies, but the analysis of the manufacturer data is not something that is launched after entering the PECON. It's like it's already running. They are finishing the data collection, and we give them to these manufacturers that have promising data collection, and we know that these data and the analysis of this data by the end of the 1 year, which is really short to launch a study, will give us the answer to the question that is interesting for us as a payer, as a government, is that is this DTX, is the DMD a useful one? Like, the security, the accuracy, that is not our concern. Like, it's the concern of the notified body that do the medical certification for the CE marking. That's prerequisite for us. And we just check, is it a useful one? And of course, we add some additional requirements compared to the MDR, which are around data privacy, data security. For the cyber security, I mean, not the safety, data safety that you have with the MDR.
All applicants have to have already CE certificate.
Yeah.
Okay, very clear.
Yeah, that's something you need. And then if you don't have it, we have this innovation funding, like when you are in the middle of getting, you already are certified like ISO 13485. You have the quality management system, but you don't have the CE marking. Then you can get funding to do the clinical study within the innovation funding. So it's for earlier devices, like even earlier in the development phase.
Very clear, absolutely. Thank you.
So we'll have these steps.
Okay, but let's move to Germany. Thomas.
Tom, yes.
Okay. Okay, so I will try to give you an overview of the DiGA in a nutshell. So what is a DiGA? A DiGA is a CE-labeled medical device that has the following properties. It's a medical device of risk class 1 or risk class 2A according to the MDR. Then the main function of the DiGA is based on digital technologies. The medical purpose is essentially achieved through the main digital function. And the DiGA supports the detection, monitoring, treatment, or alleviation of diseases, or the detection, treatment, alleviation, or compensation of injuries or disabilities. And the DiGA should be used either by the patient or jointly by the healthcare provider and the patient. So and I have written it down that prevention is not part of this. So that was also a discussion in Germany. Several manufacturers or also people from the healthcare scene, they criticized this, but I think it's definitely linked to this problem in somehow measuring the effects. So far, how many applications as DiGA so far? So we have a very recent publication here. It's 2011 applications in general. And so we have 2 entry roads. I will go on this further down. So we have the preliminary status route. There we have 166 applications so far. And then we have a permanent status. There are 45 applications so far. So this is just some links to the legal framework. If you're interested in further information, you're very welcome to look it up there. And there are several requirements that are placed on the DiGA assessment. So first of all, safety and functionality, quality, data protection and information security, but most important of all, the proof of a positive supply effect. And that is actually the big challenge. Therefore, you usually need a clinical trial or similar stuff. And that's the thing that makes it quite expensive for startups. And so there are, as I said, there are two entry roads. You can either have a final decision or a provisional inclusion in the DIGA registry. And so for the provisional inclusion, you have to, that's similar to what Vincent said, you have a plausible justification that your DIGA has positive effects, but you do not yet have the results of a systematic or clinical trial. And then the BfArM, which is the Federal Institutes of Medicines and Medical Devices, they have 3 months to give you an answer. And then they can say either no, for some reason, of course they have to justify, I guess, or they can, yes, you are included, and then you have 1 year to give the study, the necessary data, and prove that that your DIGA has a positive effect. And if you already have the data, then you can apply for the permanent registry in the DIGA. And then I'm not really sure that it's also the 3 months. I have a slide later on, maybe that it shows clearer. But then you are already listed, and then you go into negotiations with the BfArM about the price that you can get. So that's actually the process. That are the two entry roads. And as I said, either you apply for, or you have to decide whether to apply for the permanent or the preliminary way. And I think the one of the downsides, if you try to go for the direct, or I think not sure about the direct or the preliminary. If they say no, then it's a no. So then you cannot reapply for this route. So I think my time is up. So then, as I said, you can negotiate for the reimbursement in the first or for the first 12 months. In the preliminary, you can set the price, but afterwards, if you are integrated, you have to negotiate. Yeah, so there are some more information for you to look up, and yeah, you're very welcome to read some more information about that. Yeah.
Thank you very much. So I would then now like to make some provocative questions. So what we discussed, that like I said, there's 2 types of digital such applications. One is actually for medical devices that is used only for professional use. Let's make a comparison. If you have a service or like X-ray or MRI service, or part of the diagnostics, hospitals or clinics don't get any reimbursement, or maybe if it's some governmental capital or investment programs, then it gets some. But usually it's a part of the service delivery process, and you buy, and the service delivery institution just decides what kind of device they are going for and what is the price. It's just included as a general price in the price model. Now, if we have a sort of digital medical device or software as a medical device, do you see any difference in this? Should it be handled differently than we are already doing with the normal sort of inputs to the service delivery? Yeah. Maybe I would just go on. Maybe André, you want to start?
I think a simple answer to your question is no. But it's a simple answer. I'll share with you very shortly the story about teleconsultations. Actually, by law, teleconsultations were never forbidden. Actually, juristically, you could have done them before as well. But for the conservative medical sector to pick up stuff or find innovative solutions in the case that they are under so much pressure and work from everyday doctoring, then it's much to expect that they can find the new ways to do stuff just beside everyday work. So we had to make it bigger to get things into use and to list it so that these are teleconsultations that we're paying for now. And to come back to your question, then I honestly think that even today, if we pay fee for service, then there are ways how to shorten basically the time that the nurse sees the patient by taking into use remote monitoring solution. Even today, with today's price, and you can just see like 3 patients instead of 2. And get the money, enough money to pay for it. But I think we need to get our attention or help to get the attention of the sector on new solutions just to get them in use faster and to help the uptake of new solutions. But yeah, to your question, I think we don't need new ways. It's just a new channel or an alternative way of providing care that has been provided before as well.
Just one comment on this. Isn't there a hazard that the service providers just fear that if they make the process more efficient, they can actually see 3 patients instead of 1 in 1 hour, let's say, or 20 minutes. They have said, now the actually financing institution will say, we will diminish the fee per one consultation.
And that's where we do come in, and that's why I say our doors are open. We're finding the ways how to start paying for what actually matters, not the thing you do, but the outcome that you get. But it's not something that can happen tomorrow. And that's why I'm saying here that like moving towards that takes time, and it takes trust between the partners to get there. Actually, we have been very actively trying not to be like the ones who are taking away stuff, but we're trying to get the collaboration, as from the first panel, going towards how to pay for how to give the right incentives, and then how to get from the other side, like the input for creating the right incentives.
Thank you.
Yeah.
Vincent?
Yeah, but this question of the digital medical devices intended for professional use is let's say it's a matter of procurement. Like if you consider hospitals, they are part of, let's say, procurement process, which are long for sure, especially for public hospitals. But what is the problem for digital medical devices? I think there are some problems that compared to traditional medical devices where you already have the internal pharmacy department, of course the doctors that will be the users, and all the other healthcare professionals, and also you have the, let's say, biomedical engineers team that is part of the process of procurement of medical devices. But now you are adding the IT department, you're also adding the DPO for the data protection officer, you're adding these, let's say, new people in the loop. So that makes something really hard to buy, because you have so many stakeholders involved in the hospital that it's not easy to buy. And also, on the other side, most of the innovative DMD are done by small companies that don't have the financial record that is expected from the hospitals. So how do we tackle that? For example, I'm launching a call for project in France dedicated to hospitals, saying, okay, you have risk because you don't know if you buy this innovation that the company will still exist in 2 years. So we take 80% of the amount of the project that includes the medical device, plus the time that you will need to do not a clinical study, but a return on investment report, let's say. And you're free to choose the medical device, to choose the use case, to choose your definition of the return on investment that suits you as a hospital, and also the KPIs that are associated with this ROI. You do that, and we give you the money, and at the end of the 1 year period that you will need to do the procurement and implement it, do a pilot, do an analysis, and so on. Then at the end, we check if you do a report, like written on this experiment, and you share it with your peers, like other hospitals. And that's mandatory. Otherwise, you give us back the 80% of the money. And the idea is that other hospitals can say, okay, this device is useful, I want to buy it, or this is let's say a shitty device, and we don't need to lose time on it. And then we can have the idea is that we decrease the barrier, the entry barrier for these small companies, and during that 1-2 year pilot phase, then we work. Do we really need to create additional fundings or financing for these devices, or if they meet the ROI, then they can, let's say, self-finance it because they will, for example, do the same job but twice as fast than previously without the device. So that's the idea. And so, of course, there are some devices that are not economically, let's say, useful, but some hospitals say, okay, we want to pay for more quality, even if we don't get economic return on investment. And also, we share the idea of this call for project that we will soon launch is that after that we share the results to the other hospitals. And the idea is that this report must be written in a way that they are transposable from one hospital to another one, at least for other doctors in the other hospitals saying, okay, that's nice, let's buy it and let's implement it.
Is this something which you can call health technology assessment by those hospitals?
Yeah, exactly.
Like
it's the decentralized health technology assessment, and we give them, we are trying to give them the framework. We will select the most promising projects that have the most chance of being, let's say, transposable and scalable. That's one of the conditions. And also, we want to focus on small and medium companies because, for example, like Philips, GE, the big medtech, they don't really need our support to implement their new software medical devices. They're already selling scanners and X-ray machines and so on. So they have their economic model that is in place, and they don't need to. They are not fully software company that need to find a way to get them, let's say, money for the next generation of the devices.
Yeah. Thank you. Robin?
And to kind of build up on that, I think we're being inherently too patient-centric about this. And what I mean by that is, why do we need to have 3 patients seen instead of 2 with a more efficient device in an age where doctors are already drowning in additional workload that they still have to do? We were talking earlier about how can we make sure that these benefits of data are realized in a way. Well, one of the ways that, or one of the downsides of data these days is the poor documentation of it. And that can in part be directly attributed to the fact that doctors don't have enough time for this documentation.
That's why we give them money in addition to the price of the device, because we want them to spend time to collect data that will be necessary at the end.
Exactly, and this is, again, this is where you come back to health technology assessment actually, which is inherently a patient-centric system. Yeah. Which it's not bad in and of itself, but it's not a perfect system. And we can talk about, see 3 patients instead of 2, see 5 patients instead of 1. At the end of the day, why not see 2 patients properly and be able to document their data in high quality so that it can be put to good use at a community and even at a societal level? And this is, I think, something that's lost in translation when we talk about these health technology assessments. And something that's, especially now with digital technologies, it's being pushed to the forefront. I noticed that there are a lot of people interested in digital diagnostics, because digital diagnostics are inherently what falls between the cracks of health technology assessment because it's so patient-centric.
Okay. So, Jarika, do you want to actually, from the financial point of view?
I'm not even sure that's from the financing point of view, but it's just like the demographic change or the amount of doctors that we have compared to the aging populations that we have. I think, and from the experience as well, most of the solutions aim to cut down providers' time, healthcare providers' time. So, yeah, I'm not sure if we can create much more time for documentation. We should make it just easier. Maybe we can use some technologies to make it easier, but I'm not sure that's where we want to spend the extra resources that come on table.
It's not even that so maybe I was unclear about this, in case, my bad. It's not about creating additional time. It's about the expectation to fill the created time with another patient, as opposed to improving the process of the patient that is already there.
Yeah, but I think this is a valid point, what Jarika has brought out also, that obviously, even now or in the future, if we see our demographics and we know already that the life expectancy is increasing, this means that already now we have more and more people with several chronic conditions, and at the same time, our ability to create new modalities, new technologies that are extremely expensive. Let's take the CAR-T, which we had yesterday. So there is some kind of conflict. And obviously, this is, I think, this conundrum or problem what we need to solve. What is optimum? Because from the point of view of the financing institutions, you obviously would like to represent your insured people and to get everybody get at least good level, not extraordinary level, but good level of care. In European healthcare, at least. Maybe in US it's different. But at the same time, yeah, this is obviously what we need to discuss and then see and keep in mind. Thomas, do you have any comment on this issue?
Yeah, so from my understanding, in the German system, you just get a certain amount of money via DRG-based for the case. So the technology doesn't matter at all. So if you use innovative technology or not, nobody cares. And that's definitely also the challenge, how to bring in innovative technology. I think you just have to, you probably have to create either a quality gap or improvement in quality or in time, efficiency. And I think that's probably the only I can just right now think of, how to bring in new technology. But the DIGA system, as I showed, is for the patient. Actually, it's not for the professional. So it's a professional together with the patient, like the physiotherapist, or maybe also if you have for back pain, you have something, then the physiotherapist can see what you're doing, but the DIGA as such is for the patient to use. So, yeah.
Actually, I recalled a couple of days ago, I talked to one of my friends who was visiting their friends in Germany, and one of them was a bit elderly, or not well, over 60, family doctor, and she was claiming that, I'm blaming Estonians, that now the government is pressing them to go digital, and they cannot actually do because they have used to not use these digital tools, and that they spent like 1 week together, and each day she was actually claiming this, that you Estonians brought us something that we cannot cope with. Because already from Angela Merkel there has been brought as an example of Estonian digital systems.
Maybe I have a question, like for Robin, that regarding a specific thing regarding digital medical devices is that compared to other devices, the thing is that what is, for example, a game changer with digital therapeutics that are implementing CBT, like comportamental behavioral therapy, that most of the DIGA are digital CBT. What is the paradox is that what does this kind of devices allows us? It allows to mainly scalability. That's from the digital world. You can treat more patients at the same time, especially a lot of patients that are, let's say, don't have access to psychologists or psychiatrists and so on. So on the first order, you have a cost increase because basically you have a demand, but you don't have the offer, so you can keep the cost not so expensive for the health system. And with the digital technology, then you can unlock that. But on the first order of economically speaking, you have a cost increase. How do we deal with that fear from the government and the social security that we have? Like, okay, if we unlock the reimbursement of digital medical devices, then we will have a cost increase.
To reword, and perhaps crudely, what you said is the only reason why our healthcare costs are not higher is because we can't deliver the healthcare. That's kind of a problem in and of its own, isn't it? Yeah. But it does kind of, the fact that that is not widely realized, especially amongst decision makers, is problematic. And the scalability of these digital technologies are inherent, are part of their charm. They can, at least, as you say, they can unlock or they can overcome some of these barriers. But I suppose it's, I mean, how do you finance that? Very, how do you even go about financing that? That's a very complex question. I think at the end of the day, without having a solution for you per se, it's about the notion of what is our health system actually in need of, and actually would love to know the insurance side of things as well. Because my take on this is that we don't need better care, and this brings me back to the health technology assessment part of it. The way that we evaluate our digital technologies at the moment is whether they outperform the standard of care. It's not whether they equalize the standard of care. And whether it's a good or a bad thing is absolutely debatable. But from a needs perspective, from what our health system is actually in shortage of, it's good care. It's not better care. The level of care that we have in many places in Europe is actually it's high quality. It works. So we don't perhaps need digital to be better than that. We need it to be as good. And
eventually cheaper.
No.
Like as good and cheaper, or because, for example, for us in France, the way we are reimbursing medical devices is that first you are evaluated based on your clinical benefits only. You got a score, and, from 1 to 1 is the best and 5 is as good as the standard of care. And based on that number, you have the price negotiation. But if you have a 5, so then you got a price decrease. You cannot, even if you can prove that you are doing a lot of economy to the system, or that you, and so on and so on. And it's really hard to be reimbursed if you are only as good as in the current framework. And
absolutely. And I suppose where this kind of leads back to is the diagram that I showed about outcome-based payments. If you're able to show that even if you have to pay slightly more, but that the return of investment is many times over, then there will be an inherent willingness to pay. Up until that point, with the activity-based payment models that we use, that might be slightly more difficult. But also, the charm about some of the digital therapeutics that we're talking about is that the health professional doesn't necessarily need to be involved. They may only have to be there to prescribe and to check in towards the very end, maybe a check-in in the middle. But they don't have to be there every step of the way. The difference between the kind of professional-led digital therapeutics as opposed to the, what are they called? The asynchronous variant so the ones that don't involve professionals at all, is the fact that those two can be differentially priced. And it's actually the one that is not used by health professionals that will be able to unlock that potential, that will be able to overcome some of those shortages that we were talking about.
Yeah.
And at that point, it's really important to understand what does it cost to, in this case, the French system or the Estonian insurance company. What does it cost them to acquire the license? Because once you have the license, in theory, it's infinitely reproducible. But this is a cost calculation that we haven't really done all that much.
No, I don't think so.
And I do especially now with the European Health Data Space, with the AI Act, with a couple other initiatives, I do invite whomever is possible to do so to make use of the upcoming regulatory sandbox environments to start testing this stuff and to be able to really start laying out some evidence in terms of these are our costs, these are the cost of implementation, these are the cost of upkeep, and this is our return of investment.
Yeah. And we have this project, it's around secondary prevention, it's not primary prevention, but it's on the use of the AI imaging reading, to help to read the imaging or secondary reading of medical imaging. The idea is like, can we, let's say, do a project to have like a national public procurement of a license of one of these AI company that are, let's say, doing these algorithms and use the license to run it on all the X-ray data that we have, whatever the hospital or private clinic have in their database, just to have a bit, let's say, good care or better care, whatever, and to try to have a, let's say, better diagnosis. That's kind of project we try to have. Don't know if you.
I think the answer to your question, like how to convince whoever has money, the investor, to like invest in innovation. I think we're getting very close, like get the facts on the table, and I think the ability to prognostically say when is the pinpoint, like when can we get stuff like back, is very important to find. And now it's the question of how much risk is the investor ready to take in terms of like having one insurer for the whole country for whole services. Our risk level is quite low. Like we need to bring the risks down compared to, for example, like in the systems like DIGAS or so, you take everything in, you pay, and you see what comes. For us, maybe that's the point that I didn't like say out so well, but we don't have those resources. And that makes it like the process of innovation, that's how you can optimize the risk. Like taking like smaller and smaller bits and getting more information, which says that if the next step is like for the first thing to be like on the first study, maybe it's on 10 or 50 patients to say what the hypothesis for the next study is going to be. And then if that's good, then we take the bigger risk and pay for a bigger like study or invest in it. So I think it's all about like how do we evaluate the risks that we can take. And then actually from our pilots, one of those showed like on not too many patients, but it showed that it actually could save us from the psoriasis patient level. It could potentially save us up to like 4 million a year, which makes us like, okay, this investment of a couple of 100,000 euros into that study will pay us off very fast. Even if it fails, then it's a risk that we're willing to take for the hypothesis that is that great of potential like return. So yeah, I think.
But for the medical imaging is quite mature area, and there are, like, say, a lot of publications that if we put the right people in the room, they can, let's say, evaluate the risk that we are taking by acquiring this, let's say, license for 1-2 years within, let's say, a European Innovative Fund budget that we.
Well, yeah, medical imaging, it's probably the most easiest case, because Thomas will cover this in the next session, where we also talk about AI, because we see that the most of the AI sort of based solutions which are getting to the market are in the field of imaging, because this is like two-dimensional, if I may say. But if you see like the other parts of medicine is multidimensional, where you need to. But I would like to use last 3 minutes to ask if the audience has any comments or questions to any of these topics that we have been talking now.
So, thanks. First of all, great panel, and a lot of interesting things you talked about. But maybe I will throw in just some ideas. First of all, we have to probably think a little bit different about the system we are all working in. So, and the loud name about it is that we don't have a healthcare at all in Europe. We have sick care at this point, right? And to go to the healthcare, we have to be more greener. We have to think a little bit different. From the payer's perspective, we have to think about investment. It's not an expense, it's investment, right? And again, to think greener, we have to think long term. So about investments, and about healthcare, about declining age, workforce, obesity, and so on. So, and if Ministry of Health, if NHS, if NGOs, if nobody is coming together and actually really consider them all as problems, then after 10 years we will sit here with the same problems and with the same things. So we have to change thinking, but not only in healthcare's like widening, but also from the patient's perspective. And I agree what was mentioned. Robin mentioned that sometimes maybe we think too much patient-centric, right? So we have to think about all those things, and we don't want to go in one ditch or in another one. We have to go in the middle. So that's my suggestion to everybody: work together. Work not only together like Estonians, French or someone, but let's work together, Baltics, Nordics, because we can be the sandboxes of these things. We can go forward much more faster with our laws and everything else, right? And we have similar systems, education systems, and similar healthcare systems, which we compare and which we can give later on to France, to Germany, to those who are lagging behind. Yeah, so just a few comments, no questions at this point. Thank you.
No, but I totally agree with what you said, and I think that we are dealing with very complex system, and how do we, let's say, take the path to harmonization. The idea is that as European countries, we have to work together, not to have something unique, but to have something harmonized enough to, let's say, speaking about the same thing, like describing and assessing the objects, these complex objects. We have to find a way to harmonize the way we cut it into pieces that are understandable, that we can evaluate and assess, and then each country will be able to take the result of this harmonization framework and pay as much as they want. But at least we will have a framework. I think the first step is to have the framework for the clinical and non-clinical evaluation of DMD. That's part of our job also. We are in a task force for clinical harmonization dedicated to DMD, and there are also a new European project that was recently funded by a EU Commission, which is EDIT HTA, that is led by Marco Marchetti from the Agenas in Italy, health tech agency, that is a multi-European country, and the idea is that we have this HTAR, health tech assessment regulation, that is entering into force, starting with the class 3 and very, very risky devices, but also in the HTAR there is a possibility of voluntary cooperation, So we push, as France, a topic on digital medical device voluntary cooperation within the framework of the health tech assessment regulation.
Thank you. I think the final word to Robin. And
Yeah, just to reflect on the patient centrism of this all. I think what's most mystifying to me is that, look, we can have the most sophisticated tools. We can have digital therapeutics that do everything that your heart desires. We can have the most advanced financing models known to man. It really doesn't matter if ultimately the patients, citizens can't use it. And what's I suppose most mystifying to all, or for me about this all, is that everything's fine until citizens become patients, and then they need to have the skills, then they need to have the capabilities, then they need to have the finances to have all of these tools. But then we're too late. Make sure that our citizens have the digital skills to access our health data, to engage with their health data, to use basic digital devices, and they will be able to do it by the time they turn into patients.
thank you very much. I think these words are very encouraging for the next steps in the European health data space, because this is actually the platform where we can rely, and hopefully by what was to 2038 we'll get all this done in the reality. Thank you very much for all panelists.
Thanks.
And I think the panelists earn one applause to this.
Thank you also from my side. And now it's time for coffee. We'll come back in 15 minutes.